we had started with technique,
Yeah.
and we said in technique there are two important parts: the static part called the frame, and the dynamic part, which is the interaction between the patient and the therapist and all the processes which happen in that interaction. We had started with the static frame and we were understanding the elements of the frame, and we had covered part of the journey. Today we start with sessions per week. How many sessions are right for a given patient? Different therapies and different schools of therapy have a very different approach to sessions per week. Freud, when he started psychoanalysis, he would see patients 5 days a week, Monday to Friday. If somebody could not come, then at least it had to be 3 days a week. Less than 3 days a week is no psychoanalysis at all. This was the traditional understanding. Even today, if you want to become a member of International Psychoanalytic Society, and as a part of it, if you undergo your own training, analysis, or therapy, then it has to be minimum 3 days a week and 2 years. 500 sessions, but at least 3 sessions per week. 5 is preferable, but 3 is the minimum. The first person to break from this was Carl Jung. So we were saying, yeah, uh, yes, sir, you're muted, sir.
If I can ask a question, the frame is what they used to call the real relationship with the analyst, and the contents were the therapeutic relationship between the analysis and the analysant in the past.
Uh, yes, you can say it's overlaps to a large extent because
Okay.
faith is dealing with reality.
Hmm.
But it is not only that, because the relationship looks real, but the way the frame is structured is informed by very deep psychoanalytic knowledge. And that
Hmm.
involves the movement of the unconscious mind and the fantasy therein. So on the surface, it looks it's a real part of the relationship. But if you go deeper, it's an approximation. It's not completely real because the frame itself talks about anonymity, about the power differential, about the privilege to the therapist, and therefore the relationship in that sense has been skewed by design. So when it comes to the cost, when it comes to the time, when it comes to the place, when it comes to acceptance of authority and hierarchy, these are the elements which overlap with the real world. The rest of it, the privilege of the therapist, many of them are even something more hierarchical than the real world and skewed for a particular purpose. So yes, there is a, if you look at one way of approximately looking at is what you said, that inside there is a huge flow of fantasy, and within the frame there is rationality embedded in the frame. But you can just put a caveat to it that this frame behind it is deep psychoanalytic knowledge, which also involves fantasy. Although in behavioral terms, a large part of the frame and the behavior which comes in consonance with the frame is real behavior. That's true. So I was saying Freud started with 5 sessions a week and minimum 3. Less than 3 was not considered psychoanalysis at all. Even today, by and large, people think the same way. Jung deviated from Freud for the first time, and from 5 sessions a week or minimum 3, he reduced it to 2. And as we saw before, he also dispensed with the couch and went into face-to-face. As a rule of thumb, you can think about mild, moderate, and severe cases. And you can look at, for mild, 1 session per week, for moderate, 2 sessions per week, and for severe, 3 sessions per week. There will be some who will need more. You always will have outliers. I know of persons who were in training analysis, and in training analysis, they would go to the therapist 5 times a week, and on top of it, they would ask for extra sessions. So this is an extreme where the person is very fragile. There is nobody to talk to, and there is huge projection on the therapist, and the safety of the room is something she has or he has never experienced. So it becomes kind of a first time addiction. You have never tested it before. So that safety, that support, that positivity, coupled with the projection of omnipotence and all the unfulfilled desires, that can easily create an addiction out of therapy. And in such cases, you have to slowly wean the person away from that addiction. But usually, the rule of thumb that many people follow is for mild 1 per week, for moderate 2, and for severe 3. In the Indian situation, we hardly ever get mild cases. Nobody comes to a therapist for a mild case. So we always get moderate and severe. When he is mild, he will be with the astrologer, he will be with the temples and mosques, he will be with the relatives, he will be trying out Reiki and pranic healing and all sorts of things. So it's only when those things don't work that the person lands with us. So we will by and large have moderate and severe. So we will be looking at generally 2 per week, at times 3 per week, but generally 2. However, given time and cost constraints, even those who need 2 usually come for 1. That is what practically has happened, at least in India, given the cost and time situation and the traffic situation. That the person will be spending 1.5 hours in commuting and 1 hour in therapy. So, and cost also is a very important element, because if you are looking at 1 per week, then whatever the cost of 1 session, we are looking at 4 per month. And say, for example, if the cost is 3,500 per session and you have 2 sessions per week, then you are looking at 28,000 rupees per month. Now that will be more than salary of many people. So even 2 per week is difficult for many, a large section of the population, especially who are young or who are students, or who are very old and dependent, no longer working. So that is what people say about psychoanalysis. It is a therapy for the rich and the working. That you have to be working and you have to be earning well to afford this kind of thing. So this comes to sessions per week. Sessions per week should ideally be kept the same. It comes in the constancy of the frame. But if somebody does not have money or time, then if he needs more sessions right away, then you can go for 3 sessions per week and then taper it to 2. Or start with 2 and taper it to 1. But classically in psychoanalysis, we try to maintain the same number of sessions per week. If you reduce, then reduce it then for rest of the therapy. Like if you have come from 2 to 1, then continue with 1, don't go back to 2. If you go back to 2, then continue with that 2 for considerable period of time. There has to be a constancy to number of sessions. It cannot be flavor of the week. Second element we come to is a very important element of break. How about a break in therapy? So a break in therapy can happen because of various reasons and how to handle it. It's very, very important. Break can happen because the patient is sick, the patient has some urgent work, he is out of station, or you are sick, you have some urgent work, or you are out of station. All good therapists, they plan their vacations in advance. So they make it known to everybody that May month or December month, these weeks I will be away. Why is it so important? It's very important because an unannounced break is taken by the fragile patient in many different ways. What does it do to the patient? First, it can suddenly bring about a feeling of emptiness. That every Monday, every Tuesday, you are going at this particular time, and suddenly that period you have nothing to do. And that brings in sudden element of emptiness, and it can also bring in abandonment. Many patients who cannot endure it actually make a call to you even during the vacations, because they want to talk to you and re-establish the emotional connect and overcome that abandonment and that vacuum. And once they talk to you even for 10 minutes, they feel reassured and they feel better. If you have to take a break, ideally it should be informed to the patient at least 48 hours before. Ideal is that you schedule it right across the year, but let's say something comes up like your sickness or somebody else's sickness, or a sudden social event you can't avoid, or a conference which comes up, then announce it at least 3 days in advance, at least 48 hours in advance. Avoid informing the patient on the same day that today we don't have a session, or last night that tomorrow we don't have a session. That brings in very high unpredictability, turmoil, emptiness, lack of constancy, turbulence, and lack of holding, and lack of reliability of the therapist. It can be seen as the therapist can abandon any time because he's disappearing without announcement anytime. So this has to be very carefully handled. If for some reason, let us say the patient says, I am feeling well, I don't need it anymore, and does not listen to you and takes a break. Or let us say he feels well and takes a break, and after some time, he does not feel well and wants to rejoin. So there can be breaks which the patient may ask for. He may say, we have discussed so much, now I want to implement it, and for implementing I want time. So let me implement it for 2 months and see how it goes. If there is any difficulty, I'll get back to you. Some patients will go on this path. Some patients may feel the exploration is too much and therefore they need a break. They want a much slower pace. And if you are not able to calibrate, they will calibrate by taking a break. Or third, something that we won't know, often they change a therapist and then come back after some time. That they may go to a different therapist, not tell us anything about it. They will say, we want a break. I want a break. I'll come back to you later. And they come back, and after some sessions, they tell you that I had been to a different therapist. The break can be small or it can be long break. If the break is small, then all the previous constants better be kept as constants. Which means, as far as possible, go for the same day, same time if possible. If it is not possible, then go for something new. And if you are following constant cost, like I believe cost to be one of the elements of the frame, and so I don't increase the cost. Yeah, Madhusudan, you were saying something. So I prefer to keep cost as a part of the frame and keep it constant. So I don't increase it annually as most people do. Most people increase the per session cost by a factor of inflation. So they increase like 7% or 10% every year. It's pre-announced that every year it will go up by 5 to 7% or whatever is the figure. I prefer to keep it constant as a part of the frame. So unless there is a long break, I don't change. If after a long break the person comes back, then I might change a cost, because that cost has been constant for 3 years, 4 years now. Then comes a very important element of termination. Freud has written a very good paper on it, analysis terminable and interminable. When do you conclude it is time to terminate therapy? And who concludes? Ideally, both of them should conclude. So how do you know? One benchmark can be absence of a symptom which used to be present once can be taken to be one benchmark where termination can happen. That's the minimum expected from psychoanalysis. Second can be absence of a symptom and adequacy of knowing oneself. Because somebody may also be interested in a Socratic motivation to know oneself. We discussed this before, that one can come to psychoanalysis for two things. One is healing and second is to know oneself. So when we are in the healing mode, we call it psychoanalytic psychotherapy. And when we are in a pure Socratic mode, we call it psychoanalysis, which is a pure Socratic approach in which healing takes place as one of the many things which takes place. That is not the central goal. But once you come to psychoanalytic psychotherapy, then healing is the central goal. For example, if somebody talks about abandonment, and if you are in a psychoanalytic psychotherapy approach, you will go into how do you feel it? How do you respond to it? What do you think about it? But if you are in the pure psychoanalytic mode, you will say, let us look at how differently we can look at it. Let us see how you see it and let us see how somebody else would see it. So looking at the same thing from very different perspectives, where every perspective may not be marching towards healing. Some of the perspectives may just allow you to know something from a different way. So that's the psychoanalytic approach of analyzing everything from multiple standpoints, including our standpoint, including the pathological standpoint. And as a part of it, healing happens. So healing is not the only objective of psychoanalysis, but in psychoanalytic psychotherapy, that is the central objective. So if you are into psychoanalysis, you will say, apart from cessation of symptoms, I would look at adequate self-knowing that when you feel you have known yourself adequately, we can terminate therapy. Some people will go ahead and also use some psychometric instruments. That let me not go by the reporting of the patient. Let me also see if the symptoms have actually ceased using a psychometric instrument. That he says he is feeling good, he is no longer feeling depressed. Let me see what the scale of depression tells me. Fourth can be the patient announces termination. Many patients do. And often it may be a defensive action. Often it may be a necessity out of time and cost imperatives. I can give my own example. And I also give Laka's example. I had to undergo 2 years of training analysis, 3 days a week, 500 sessions. It will take practically 2 years. So 2 weeks before my training analysis was about to end, I told my therapist, okay, I have 2 more weeks to go to complete my academic requirements. And I have healed to some extent and known myself to some extent. It's not complete, but I can't carry out any further. So as soon as my academic requirements are met, I'll be requesting termination of this therapy. So I announced it 2 weeks before, and he was taken aback because he never expected. He expected it to go on and on for quite some time. So this is one way that you complete your academic requirements and then you announce the termination, probably 2 weeks or a month in advance, preferably a month. I think I did it a month before. Yes, I did it a month before. And because complete self-knowing, complete psychoanalysis of anybody is an ideal, it's not possible. And if you have time and cost, only then you can go on with it. It's an extremely costly and time-consuming process. But if you have the luxury, you should go on with it, nothing like it. Some of my batchmates had the luxury and they went on with it for quite a few years. I think some of them went on with it for almost 7 years. Laka announced termination in quite a different way. After his requirements were complete, he told his therapist he was done with it. And many people, including me, believe that he was genuinely unhealed. And his announcement was very narcissistic. This announcing the termination of the therapy without taking the understanding of the opinion of the therapist into it was, and after the therapy was over, what he did and what he said and the way he lived, it brings out that element that he was genuinely unhealed and he required far more therapy, but he terminated it in a very narcissistic way. So Laka is very fond of gnomes. Gnomes means one statement which has multiple meanings. Like he would say, desire is the desire of the other. It would have multiple meanings. Like the desire that I have is of the other. The second meaning will be the desire I have has been given to me by the other. The third meaning will be my desire is the desire of somebody else who desires somebody else. So there will be multiple meanings of a gnome, and Laka was very fond of this kind of statements of multiple meanings. So I always use a gnome for Laka and the gnome is Laka needs a tranquilizer. And when I said this to my teacher, he was taken aback because he was very fond of Laka. But ironically, his therapist had the same opinion as me. So this is the termination. It's very, very important. When do you terminate? Now, different schools have different ideas about it. Strictly clinical schools will look at cessation of symptoms. If you are a strict Bionian, Kleinian, Freudian school, by and large, cessation of symptoms and some form of adequate self-knowing will be enough. But if you are in a Jungian school, they will look at individuation, becoming what you really are in potential. So there the goal is not only of healing, but also of self-growth. So we have two different goals. Healing and self-growth are two different goals actually. So if self-growth also is a goal, then of course it will go on for years, because self-growth is going to go on for years. If you are in a Lacanian framework, then somebody can terminate it after an exhaustive articulation of desire and having converted the symptom into a symptom. There is an old anecdote about a Lacanian analysant. A person came to Lacan, his problem was whenever he would come out of the bar every evening, he would go to the wall adjacent to the bar and publicly urinate there. So he went into analysis, and after a few years, he stopped the analysis and again did the same thing. So somebody asked him, what happened of all the analysis that you did? So he said, now I know why I'm doing this. So that is a very different kind of termination, that you are not looking at even cessation of symptoms. You are not looking at individuation. You are looking at a reasonable self-knowing, a reasonable articulation of desire, and conversion of symptom to symptom at the minimum. So different schools have a very different approach to termination. If you are in very different kind of therapy, say for example, you are in CBT, many people in CBT follow a 12-session format. So then termination takes a very different route. It's pre-decided that we will work only on one problem, and for this problem, we will work for 12 sessions, and after every session, I will give you homework, self-work to do, and only after you finish it, we have the next session. And the ideal expectation is it should be 12 weeks. 12 weeks, 12 sessions. So in the very structure of the therapy, termination is built in. It's not an open thing. In many short-term therapy approaches, it's built in. Okay, we will do X number of sessions devoted to this particular problem. We will not discuss anything else except this problem. But in psychoanalysis, this is a very hazy area of termination. In long-term therapy, it's not easy to terminate. It almost appears as though there is a platonic love going on between the therapist and the patient. And termination involves detachment and mourning on both the parts. And often that sadness is avoided by both under different pretexts. And therefore, in classical IPS training, they insist that you should have at least 2 patients that you have seen for 2 years at least before considering you a real therapist, because that person would have undergone that detachment, that mourning, that sadness of detaching from somebody you are seeing every day or 3 days a week at least for 2 years or more than 2 years. And it is such a sad experience, the separation, that both parties try to avoid it. And one of the ways of avoiding is to continue it in a more tapered way. That instead of having 2 sessions per week, let us have 2 sessions per month or 1 session per month, which is a way of avoiding detachment. There's nothing therapeutic about it except that you're avoiding detachment. Now, if the therapist does it, tapering, that may be a requirement of the patient. But the therapist also requires the same thing. Then it is trouble in the sense that both of them have got entangled in some way. So long-term patient's termination is something you have to undergo experientially if you have to really be a seasoned therapist. It's a very hard experience, very difficult experience. Many people actually are unable to go through it and they actually fall back, and many of them end up having relationships with the patients. Because the kind of method we are using evokes such primal and such strong emotions that it is very difficult to control it. It's easy if you're doing a conscious mind-based, willpower-based, reason-based therapy. If you are into CBT, REBT, DBT, it's easy. But when you evoke strong unconscious emotions, strong unconscious templates, it's very difficult to keep yourself away. It's very difficult to deal with the counter-transference. Very difficult to deal with projective identification. So termination is something one has to go through at least once or twice to really have a feel of it and how difficult it is. And one can understand if it is so difficult for us, how difficult should it be for the patient? Even more difficult. Emergency session. This is something very important. Yeah.
One was we said termination can be based on freedom from symptoms.
Right.
Is it not more logical that we should have some psychoanalytic construct to be measured or repeatedly, regularly? For example, ego strength or the narcissistic approach to my work. If that is contained, I measure it once, twice, 4 times, and then I decide it should be terminated. Or if my ego strength has increased, or my attachment style has become more secure, then it should be terminated rather than just absence of symptoms.
Yeah, I mean, what you will be doing there will be, you will be making the absence of symptoms official.
Okay.
Like, for example, somebody has come with depression and he is now able to go to work, he is able to relate to anybody, food is okay. I mean, all the criteria of depression are unmet, which were met before. So when we say that he's no longer having those symptoms anymore, now if you want to make it official and more rigorous, we may administer a depression test.
Then depression test, there should be some psychoanalytic parameters that we measure
Achha,
rather than giving him just a depression Hamilton scale or whatever it is.
okay. What will happen is कि generally in practice, you're right, we should have it. People don't use this kind of thing, but we should have it. But usually there is a triangle of corroboration. Like, what is his work life like? What is his personal life like? And how do you see him in the session? Because when you see him in the session depressed, and when you see him in the session undepressed, it's very different. You can make out whether a person is depressed or not depressed. And if not being depressed continues for session after session, and of course, if we are not dealing with a bipolarity, then a qualitative assessment of cessation of symptom is done. And if you want to back it up with a quantitative thing, then you can use certain scales which are based upon psychoanalytic knowledge more than non-psychoanalytic knowledge. And you can find out such scales. But what has happened in the last few years is, because we want a common language and a common diagnostic tool inventory, the same tools are being used everywhere.
Okay.
So what is used in psychiatry is getting used here also. The same Beck inventory, the same Hamilton inventory, the same Briggs-Meyer tests.
Mhm.
And in practice, actually, very few people even use this kind of tests.
Yeah. Interesting. Question was regarding the change of computer, variable session, and changing session duration. We have not considered these 3 points, or they were considered previously.
Which ones?
The change of computer online, the variable session Lacan sanction,
Okay.
and the changing session duration sanction.
Okay, we have done it last time, but I'll just make a mention of it again.
If I have forgotten, but
कोई बात नहीं.
this week we did not have a session, no? We did not have a lecture.
अरे last to last time.
Okay, okay. Senior moment, I'm sorry.
कोई बात नहीं. The online point is related to the constancy of the frame. That how we have to maintain everything constant. And in case of very fragile patients, I give an example of how I changed from laptop to a desktop. And the laptop was very old, in which the camera was very low resolution. I was hardly seen. And suddenly one day I changed the computer to desktop, put on a new camera, and I was completely up against him. And he found it very unsettling. I also mentioned about an example that in many mental health institutions where very fragile patients are held, people actually use a uniform. They don't even change dresses every day. So this is one point. The second was variable session. And in variable session, sanction is when you put an end to a variable session. Now, Lacan was the only person who was using variable session. And the idea was that free association can be used as a defense. And if the person uses it as a defense, then we end the session so that the person knows that because he was not sincerely working on himself, but using the freedom as defense, the session has been cut. Or the person says something very important and the session is cut. So there, termination of the session, not the termination of therapy, termination of the session is used as an act of interpretation. But this is introduced only after some sessions have gone. You don't introduce sanction in the first few sessions. It's after the good, reliable, stable object has been established and to some extent internalization has happened and the person has stabilized. Initially, it would be too much and most people won't be able to bear it. So after some time, you bring in this element that if you use free association as a defense, we can terminate the session. Or if you say something very important, we terminate the session. Or
important. Why after saying something important?
So that he does not go anywhere else but keeps reflecting on it.
Oh.
Because usually where we complete the session, it goes on in our mind for quite some time. And if we tell him upfront, this is something very important, so let us stop here, which means this requires far more contemplation. Then emergency session. Emergency session is something where a therapist is lucky and the patient is unlucky. Patient is unlucky because he requires an emergency session, and the therapist is lucky because these are the sessions which the patient goes out of his way to ask for, and maximum and easy change can be achieved in these sessions. Never say no to an emergency session, because the whole thing is boiling and on the surface. You can achieve in one emergency session what you can achieve otherwise in 7 sessions. So never say no to an emergency session. Anonymity. Why so much emphasis on anonymity, and to what extent can it go, and to what extent can we actually be anonymous? All the three are very important. Psychoanalysis wants the therapist to be blank screen. Why blank screen? So that we can solicit transference. The more strictly you implement the frame and the more anonymous you remain and the less responses you give, more transference will come. The purer you implement the frame, more transference will come, deeper transference will come, purer transference will come. And this is something very few people understand. People believe if we implement it to the dot and we awaken the deepest and the strongest and the most primal of transferences, we are a great therapist. It's not true. It's a horrible thing to do if you don't know how to handle. So the question is how human can be. It depends upon how pure a transference you want. I'm not saying how pure a transference can you have. How pure a transference can you want? How deep you really want to go in terms of the healing, in terms of the analysis. And second, how much can you handle? Do you really have the containing capacity, the knowledge and the tools to handle a very, very pure transference, a very deep transference, a very primal transference? So work with transference to the extent you are capable of. Work with the transference to the extent the patient can take. Very difficult transference is evoked, the patient can't take it. At times we can't handle it. We don't have the skills to handle it. So don't awaken what you can't manage. Too much of transference is as difficult as too little transference. Too deep a transference is as difficult as too shallow a transference. So if you believe that you have been extremely anonymous and very deep primal projections are taking place and the patient is not able to handle, or you don't have the skill, then indulge in a bit of self-revelation. Your self-revelation will break anonymity and break the purity of transference. So how human can you be in the therapy room depends on how much transference you wish to solicit. What is the quantity and quality of it? For example, if there is a very strong Oedipal transference and the patient can't give up, the therapy will end. Because either you will fall into a relationship and the therapy will end, or the patient can't take the rejection and the therapy will end. Similarly, once you have an omnipotent projection, you have to be extremely careful even in indirect criticism, because that can be seen as a disapproval and attack by an omnipotent figure. Even giving the name of the problem somebody is suffering from, that itself can shatter a fragile person. Because once a fragile person makes that omnipotent transference onto you, in many cases, if you say that this borderline thing is coming up again more last week, isn't it? The very labeling is seen as an attack by a fragile patient. The extremely fragile patient doesn't want you to even use the diagnostic name. Even that is seen as an attack. And the patient often will tell you, I am far more than only that. That I am not only a borderline, I am far more than the borderline. Only a part of me is borderline. It does not exhaust what I am. This label covers only a part of me, not the full of me. So self-revelation can help in undoing of projections, undoing of very primal transparencies. So one way is, then the question is how much self-revelation to do. If you do too much of self-revelation, you are no longer a blank screen and the projections don't come. If the projections don't come, you can't work because a large part of your work is in projections. You work with the transference to heal the transference. You work with the projection to heal the projection. Unless it is evoked operationally, how do you work with it? Otherwise, you will be talking conceptually with the person, not experientially. And conceptual talking will not heal. Experiential work will heal. And for the experiential work to happen, what has to be healed has to be evoked. So all problems in life will have to play up in therapy with you. The problem he has with everyone else in life will come up with you. Similarly, the early life unconscious elements will get projected out in the therapy room. And only when they are evoked can you identify them, catch them, bring them on the table of analysis, and explore feelings related to them. So there is no option of not being the blank screen. So we have to calibrate our self-revelation and do it only when needed and only selectively in a calibrated way. The next question is, how far is, yeah, please.
Sir, the question, how pure a transference can you handle? How do we differentiate if the patient is going into transferential psychosis rather than a neurotic transference on which we could work?
The first part is, when has the transference come? After a long neurotic therapy, if you are going deeper and something is psychotic, evoking which is psychotic, you are actually going deeper. So it's actually, you are unfolding the repressed psychotic part of the person. It's not likely to precipitate a psychosis. But very early in the therapy, if psychotic things come up, then you are dealing out and out with something psychotic.
What I meant was by transferential psychosis is, so you are like my grandfather. Other than that, if the patients insist that you are my grandfather and you must do this for me.
Correct. Correct. So that is where the transference is getting more than we want. It can happen even in case of, not only in case of identification, even in case of displacement of anger. That the person is very angry with the father, he puts all the anger onto you and fights with you. And then you have to undo the projection by bringing the reality and use interpretation to say, I am not your father. So when the what we do is we become anonymous, we solicit that transference, and when that comes, we interpret to heal it. Now, if it is not coming at all, how do we heal it? It has to be awakened experientially to heal it experientially. And to awaken it, we need to be anonymous. We need to be safe. We need to be acritical or moral. We need to have that therapeutic alliance, which is the healthy part of the therapist and the healthy part of the patient. They are unconsciously in alliance, which is called the therapeutic alliance. So the therapeutic alliance is very, very important, and we have to be very careful in interpretation also, because every time you interpret, you are chipping away at therapeutic alliance. Every interpretation is at the cost of therapeutic alliance. So the therapeutic alliance is the capital you have to spend, and you should not spend it too fast, too much. It's a therapeutic alliance which is keeping the show going. And every act of interpretation, every act of challenge, every act of confrontation chips away at that capital of therapeutic alliance. One possibility related to what you said can be this. The frame is held strictly, anonymity is held strictly, confidentiality is held strictly, and the person is fragile, and he goes on the couch over and over again, and slowly he starts sliding from the neurotic to the psychotic. And this is where the psychotic symptoms start coming up even before you have really gone deep in therapy. And that is where we talked about the patient who is not a patient of psychoanalysis. And this happened to one of my teachers. He used to teach us clinical psychiatry, but he would not teach us psychoanalysis. The reason being, he himself had not completed the training analysis. And what happened to him was this: he went into training analysis on the couch, the frame held strictly, anonymity held strictly, and within a couple of months, he started having psychotic symptoms surfacing. And he had to stop the therapy process. And he stopped the therapy process because he was not a patient of this particular technique. It's too much for him. How far is it possible to be anonymous? Even if you want to be. For example, you can't hide your name. You can't hide your qualification. Your office is situated in some area of your city, which tells you about the economic status. Your designation tells you about your achievement or non-achievement. The way you relate to everybody in the organization tells something about you. Today, even a social media profile will say something about you. And therefore, all strictly psychoanalytic people should not have an open social media account. So it's very difficult. And when the person comes in, he knows your taste and preference by the look at the room. The colors you choose, the interior decor you choose, the type of brands which are found in the room. And of course, your dressing and the way you behave. So beyond the point, we can't really be a blank screen. Even without self-revelation, even without our will to self-reveal, we do self-revelation. It happens. Look at Freud. Freud's room was filled with artifacts. He was very fond of collecting ancient artifacts. They were all in his therapy room. And when the patient came in, he would know that Freud is interested in all these kinds of things. So it was a breach of anonymity. But the ideal is to be as anonymous as possible. How far can we go? Very difficult. Especially in the city situation, where a city is small and you bump into each other in social occasions or conferences or some sort of that thing. How far does one have to go? Depends on the therapist. One of my supervisors gave up music because his therapist told him that if you want to be a therapist, you have to be anonymous. So either give up therapy or you give up music. He gave up music. Some people go so far as not even to announce that I am a therapist. I got to know about somebody who was a professor in a college, and on the side, he was also doing therapy. And I never knew he was a therapist till I knew him for say, almost 5 to 7 years. It was only towards the end of, I think, 5 years or 7 years, I asked him, and he told me, yes, I do therapy. Now, of course, he could do it because it was not his main profession. Now, what does anonymity facilitate? Why do you have so much of emphasis on anonymity? First, transparency. Second, projection of omnipotence. Third, safety of doing projective identification. Fourth, not fearing to express something. That if some person knows I am a Modi fan and he wants to criticize Modi, he won't. Some person knows I am not a feminist and he wants to speak something harsh against men, he cannot. So the person should be completely free to express, and there should not be any lure. For example, if somebody is a director of a place and also a therapist, and the student feels that tomorrow he will interview me, he won't actually speak his mind really freely. So there should be no fear or lure of your real position in society. And very importantly, you should not be in discussion. So anonymity has many purposes. One of the purposes is that you should not be in discussion, meaning the therapy time is for discussing the patient, not discussing you. Now, if you reveal yourself and you become a part of discussion, it's your therapy, not the patient's therapy. So this is a very important element of anonymity, that you should not be in discussion. The patient should be in discussion. Yeah.
To the other extreme, is a criticism against psychiatrists or psychologists that they always want to be invisible.
Sorry?
They want to be invisible.
Ha.
And anthropologists have done that critique, I suppose, that they don't want to take any responsibility for anything. Patient thought the need, patient felt so.
Ha.
Where analyst did so, client thought it necessary. That was
Correct. Correct. So this is related to anonymity. Any questions on this anonymous part? Should we break for a cup of tea? Yeah, please, Madhusudan.
Sir, in the Indian setup, this kind of anonymity is maybe can backfire. Patient might find that they are getting the patient might abandon therapy because they feel that this person is not making a relationship.
Right.
Is that possible?
You can bypass it. You can bypass it. What happens is the natural feeling, as you rightly said, is that both people have to self-reveal in a conversation. That is natural in Indian society. Right? One person keeping it anonymous is very awkward. It can also be seen as looking down on somebody, creating an unbearable hierarchy.
Yes.
Right? A rude hierarchy, so to say.
Yeah.
So what happens is we put it on the third person, the guideline. We have invented a punch bag called the guideline, and we deflect all the rage that was to come to us on that punch bag. So here what people do is people say, if the people, I mean, it's very normal. How is your wife and your kids? It's a very normal question. I mean, it's not a crime to ask it. It's a very normal question, a very socially conventional question, customary question. So you just smile and you say, the guidelines of therapy are such that I can't say anything about myself. And this whole hour that you are paying for has to be at your service. So I'm sorry, but I won't be able to say anything about me because my guidelines don't allow me. There are strict guidelines of therapy. So instead of saying, I won't say, you say, the guidelines don't allow me to say. And that is taken to be something palatable because the other person feels that he is not rejecting. He does not have the freedom to do it. So
I
that
did
is
not follow the original question. I'm sorry, Madhusudanji.
So, sir, I was thinking like, take for example, family therapy. You end up becoming a member of the family. Then they want to call you home. And then if you don't go home, they feel very insulted. So then will that harm the therapy or what? That's what I was thinking.
that is classically not Western psychotherapy
Right, right.
because Western psychotherapy is, except for the behavioral therapy, is largely based upon the principle reflecting, not acting. So it never goes out of the therapy room. So the therapy cannot go out of the therapy room. Now, this is more like an Indian version where you say living beyond reflecting, where the whole idea of the guru or the guide is to be with the person 24/7 and always available. There are no session structures. So it's a very different way of dealing with the whole problem. It is not actually Western psychotherapy. So the Western psychotherapy model is the therapy never goes out of the therapy space,
Okay.
except in behavioral therapy, where according to a pre-designed behavioral intervention, you are with the person, but only for that purpose, never for a social occasion. Now, asking somebody to come home is a social occasion.
Yes.
So that's a strict no-no, even in behavioral therapy. So that is strictly speaking not Western psychotherapy. It is more
Yes,
like
but in India, that's like what I was asking. What do we do in India?
so. This is where we have to start in the first session itself, because in the first session itself, before the therapy starts, you are just introducing, getting to know the problem. You make it very clear at that point the frame. The therapy process works according to certain do's and don'ts. And these are the do's and don'ts. So please don't feel bad because I have to abide by these guidelines, not for any other reason, but for your interest. That if we abide by these guidelines, the healing is faster.
Okay.
So over years of experience, people have evolved these guidelines, and till the problem is solved, I have to abide by these guidelines in your interest.
Right.
After the therapy is over, your problem is solved. After that, we can think about it, but not now.
Okay. Thank you, sir.
Now, one of the elements is even after termination of therapy, some people will still hold the frame because there is no guarantee that a problem will not occur after 5 years, 10 years, or 15 years. And if the frame is broken, your ability to help the person reduces considerably. And if he has to go to some other psychotherapist, to start all over again is a very difficult process. It will take that kind of time and cost and familiarity and trust and the whole luggage of things. So it's very difficult to start anew, especially at a later age. So what people do is even after the therapy is over, they hold the frame. So that till the therapist is alive, anytime the patient has a problem, he has a safe place to go where he is already pre-understood in a way. Contrary to this, Some people have taken exceptions. For example, certain forms of existential therapy outside of psychoanalysis, they think of therapy as a social occasion. Jung also used to call it a social occasion. That in addition to everything else, the person also has a problem. Like one of the patients came to Jung and he said, so you are in soup too. So you are in soup too. That I am in soup and now you are also in soup. Now that kind of self-revelation in classical psychoanalysis, nobody will do. The therapist bringing in his psychological problems is one of the extreme forms of self-revelation. And as I said, self-revelation has to be very calibrated, done much later in therapy and only for a purpose. When you think that the transference will become too strong and not in the interest of therapy, only then you bring in self-revelation. Or you have no choice. Like I got an accident and many people came to help me. I avoided all the patients as far as possible. But they might have got information from those who helped me. So with the patients, I could still maintain the frame and not get them involved in my sickness. But some friends I took help from, and they may know the patients and do the revelation for me. That you can't control. But as far as possible, make it guided. Make it calibrated and use it only as necessary and never do too much of it. Because one of the reasons what you say has value is because of the omnipotent projection on you and lack of reality knowledge about you. So if you tell the patient that why don't you contemplate more on this area of abandonment? If he knows about you, he can turn back and tell you, why don't you do it before you ask me to do it? You have been in this area for so many years. Have you solved your problem? If no, how are you to solve my problem? So then you come into discussion. And that is what we don't want. The therapy should be about discussing the patient, not discussing the therapist. And the moment self-revelation happens beyond a point, you get into discussion. Should we stop for 10 minutes, have a cup of tea and come back? So it's 4:47. Let's come back at 4 o'clock.
Link, sir, or the same link?
Same link, same.
Thank you.
One important point which came up in what Madhusudan said is this. What if something works in the Indian context, but it's not thought of to be right in the Western context? Then we have to go by what works. Because in the ultimate analysis, we have to get results. And if we get results through an Eastern method, that should not be a problem in the first place. So there may be a group of patients where the Eastern methods may work far better than the Western methods, and there's no problem in going with that. Finally, we want results. So this is how it is. I'll give an example. Two examples I'll give. One, I was seeing a patient and she was a very good cook. And like any other very aged Indian lady, she said, why don't you come to my home and I would like you to sample some of the things that I cook. Now I brought in all those guidelines and everything. And she said, finally, koi baat nahi. Once the therapy is over, then I will invite you. So, then you will come definitely. I said, okay, fine. So that is one part of it. Usually the best answer is to say, we will see, but in Indian condition, you will have to say, fine enough, then I will come. And you know that's not going to be there. Because when that happens, you will say, no, I will hold the frame. What if it's needed later on? So one of the few places you have to lie in the interest of the patient. Second example, this one of the principles of the frame we said, not taking anything from the patient other than the fees in cash or in kind. And this kind goes as wide as it can go. Now, why do you say that? Let me give an example. One of my teachers, when he was in his training analysis, he was studying psychoanalysis, and as a part of the course, you are supposed to undergo your own training analysis and also see patients under supervision. So he was seeing patients under supervision. So one day it happened that the patient brought a chocolate, and she was a woman, and this therapist was a man, and she gave a chocolate to him. And this man had heard everything about what these gifts can unconsciously mean. Okay, what does it mean if a patient gives you a chocolate? What does it mean if the patient gives you 3 paintings out of 12 paintings that she has made? So he had heard about all that unconscious interpretations of those things. So the moment, and this happened in Ahmedabad at a place which was about 2 kilometers from the place of the supervisor. So therapy room was 2 kilometers away and the supervisor was working somewhere else. So this man, after the therapy session was over, he took that chocolate and he was so anxious, he ran to the supervisor's office. And there was a lift in that building, but he could not even wait to get into the lift. He just ran up the stairs. And he opened the door and he told the supervisor, the patient has given this to me, now what to do? And the supervisor said, now eat it. Because the whole point was not to take the chocolate. Now that the chocolate has been taken, you better eat it rather than throwing it away. So it's a very important thing not to take anything in kind. The patient may bring, say, 2 pastry cakes on his birthday. Or he has gone somewhere on a tour and he brings gifts for everyone and one gift is also for you. Or on a Diwali New Year vacation, he brings a box of sweets. Now, the Indian customs clash here with the psychoanalytic thing. That it may be thought of to be rude not to take it. So it's better to make it very clear that I won't be able to take anything that you give right before the first session begins. But if somehow that has not been done, then take it. And after, thank him, take it. And after a few sessions, make it a point, okay, this I can't do. I have done that, but I can't do it again. Okay. Yeah, please. Sir, we can't hear you. Can you repeat it?
Thing that summarizes such differences across cultures.
Right.
If not, we should take it up.
Correct. And that is why the psychoanalytic frame applied in India is much looser than the psychoanalytic frame applied abroad. We can't do it exactly as they do it unless you are into training analysis or you are dealing with the urban, well-educated part of the society. confidentiality. This is a very important part of the frame. And the first point of confidentiality is that the therapy room should be such that neither video nor audio goes out of it. People often create therapy rooms, which is like a partition that you have 2.5 feet of aluminum and then you have glass. And the glass is audio proof but not video proof. And in many cases, it is not even audio proof. So strictly speaking, unless there is a audio proof, video proof room, strictly speaking, psychoanalysis cannot happen. Because that anonymity and the confidentiality is very necessary for the person to speak what he wants to speak, what he cannot speak without a sense of shame in normal society. Otherwise, if the society gets into the room, the person is no longer safe and he won't speak what he wants to speak. So the society can't get into the room. In the room, it should be only the therapist and the patient. And the moment there is no video confidentiality or audio confidentiality, the society gets into the room. So the big other has to be kept outside of the therapy room. All the others, the big, the other, the micro, the mini, the nano, all forms of others have to be outside the room. I remember I was attending a supervision session. It was a group supervision, and one of my teachers was doing it. And the person who was presenting it was working in a university in Ahmedabad. And the university had allocated a small room in a corner, the least important of all rooms, as a therapy room, because it was necessary according to UGC mandate or something. So this person used to go there twice a week or thrice a week, and that room did not have audio or visual video confidentiality. There was glass and therefore you could see it and you can hear what is said inside, outside of the room. And I remember one of my teachers, he refused to supervise that session because he said this is not a psychoanalytic session. That a psychoanalytic session will happen only when there is preferably both confidentiality, but audio confidentiality is even more important than video confidentiality. Because video confidentiality is, even if it is not there, you are not going to do anything. You are just lying on the couch or sitting on the chair. But audio is where large amount of action is. You are inhibited by the frame not to get out of the couch or not to get out of the chair. So there is not much visual action, but there is all of audio action. So there is a lot of action inside the patient, and outside of him, it's all audio action. So the audio confidentiality is actually even more important than the video confidentiality. But ideally speaking, it should be both. First aspect of confidentiality. Second aspect of confidentiality, there should be no leakage of information. You should not discuss it with anybody, not even with your supervisor without permission. And even while you discuss it, you should always camouflage the personal particulars of the person. No identifying information should be shared, not even in supervision. No paper writing should be done without the permission of the person, not even without giving his personal particulars. Even if his personal particulars are not given, even then the paper cannot be written without his permission. If you are doing a video recording, like you do in ISTDP, there has to be a prior written sanction from the person to do video recording. If he does not allow, you cannot record. And there has to be a separate consent taken if you wish to use that video for training or supervision purposes. Ideally, you should keep enough time between two patients so that they don't cross each other in your therapy room. You should not have one person in the waiting room and the other person coming out of the room and both meeting each other. Often it can be socially a very awkward situation. And the patients coming to you as an information may be passed to somebody does not want to pass. Like if you have a session 6 to 7 and the second session is 7:05 to 8:05, only 5 minutes of gap, 5 minutes can easily be delayed in the patient getting out of your room, giving you money, going for a glass of water, going to the washroom, or just talking to the receptionist or something. So between the two sessions, I prefer to keep a gap of half an hour. That is on the liberal side, but most people at least should keep 15 minutes. So that the crossover of two patients is avoided, and you also get time to disengage from one, get into a neutral space and ready for the other. In that quest for money, many people don't observe this. They have patients back to back. So ideally, you should not take more than 3 to 4 sessions a day and not more than 15 sessions a week, and at least have half an hour of gap between two sessions. So it's like it's a profession which you should take it easy. This is not a production line in a factory. And never try to be hyper busy that I will do 7 to 7:30 patient 1 and 7:40 to 8:10 second and then 8:20 to 9 the third. Never have this kind of hyper busy thing. It's not good for your mental health, not good for quality of your work, and definitely not good for patient well-being or anonymity or confidentiality. Some countries have laws where the psychotherapists are not allowed to put up a board outside their office that this is an office of psychotherapy, because they don't want anybody should see the patient going in and coming out, because everybody would know he's going in for psychotherapy, and that can be stigmatic, that can have an adverse impact on personal and professional life of the patient. So many states in the world have this kind of a law that you don't put up a signboard outside your cabin. This also brings into this element that you should not take into therapy anyone with whom you have a dual relationship. So the guidelines tell us that you should not have dual relationship with any patient. Like if you have a patient, you should not have any business with him outside of the therapy room. And therefore, we should not take any family member, any relative, any friend, any business colleague, any business associate in therapy. And we should not also take two members of the same family or two very close friends, because this will get us into a triangular difficult relationship or into a dual relationship. Some cases it is unavoidable. For example, you are a teaching institute, you are the only one in the city teaching psychoanalysis, and students come to you and you are also their therapist. So you are a teacher and therapist two in one. So it may be unavoidable in some circumstances, but as far as possible, no dual relationship. And not taking anybody related to us or related to somebody who is in therapy. Unfortunately, to make money, many therapists that take multiple people from the same family, that the child is coming for therapy and then the mother comes for therapy and then the father comes for therapy, should not be done. As far as possible, if you get this kind of references, refer it to somebody else. Because what will happen is, if you do therapy well, the word of mouth will go. And if there are two people in the family both needing therapy, like it has happened many times to me, that I am working with one person and his sister or brother also wants therapy because the family environment was very difficult and all the siblings have problems. So now the person tells me, can my sister or my brother come? And I refuse. I say, no, I'll give you a reference, you go there. But as far as possible, avoid it. If there is no other way, that there is no good therapist, or the problem is such that you specialize in it, or they have tried everyone and they are not satisfied, then in this situation you can take that risk. As far as possible, do anonymous discussions. Like the patient says, I want to be a great businessman. Only if I can overcome this. And you want to, let's say, for example, the situation is such, you want to give an example and say, X is a businessman and he had the same problem like you. And he overcome that and he is successful today. So you can also be equally successful. Let's say you want to say this. As far as possible, don't take names that your neighbor, he also had this problem and he overcame it. As far as possible, keep the discussion anonymous. Don't bring in real persons from your side. The patient is free to do anything he wants. But from the side of the therapist, let your discourse be anonymous. Don't bring in real life people as far as possible, unless you're talking of some celebrity who neither of you knows and he does not know either of you. But never bring in real life people of the city or somebody who can get in touch with the patient in discussion. In certain countries, laws are there to maintain confidentiality. And it is illegal to break confidentiality, and you have to actually sign a contract that I will maintain confidentiality. And law also suggests that you have to break confidentiality when harm to self or harm to others can happen. So the therapist has both these compulsions of law: maintain confidentiality always, except when harm to self or harm to others is imminent. At that point, it is incumbent upon you to break confidentiality and inform the police or inform the psychiatric service. In some countries, people have tried to argue against this law. And they have cited something which is in law, which is called privilege of the priest. Because in the Christian world, there is something called confession. And you cannot ask the priest to divulge who has confessed what. And that cannot be used in the court of law as a evidence. And the priest is not bound to reveal what X or Y has confessed. So that's called privilege of the priest. And people often invoke that doctrine to say we should equally have the privilege of the therapist. That even if somebody is saying I will harm myself or harm others, and the therapist feels he should still not inform the law, he should have the privilege. That he is the best judge whether it is going to happen or not happen. And if he feels it's an empty threat, then for something histrionic, why to break the frame? Because once the frame is broken, it's very difficult to repair it. Once you have broken confidentiality, it's very difficult to regain the trust of the patient. In all probability, he will leave. So if somebody is histrionic or manic and says this thing, then is the therapist not a better judge to treat the utterance as one of a histrionic or a manic rather than take it seriously? As of now, we don't have that kind of protection. So most countries have the law of confidentiality every day and compulsorily break it when harm to self or harm to others is imminent. As I said, some people go to the extent of even hiding that they are therapists. It's only in the professional circles and through word of mouth it spreads. Or they make a presentation and it spreads. But till somebody asks them, they don't say. So it is a kind of limit of confidentiality and anonymity that unless asked for, you don't say, I am a therapist. Any questions on this technique? So this was related to the static part of technique. Next time we will do the dynamic part of technique, which is transference, counter-transference, projective identification, containment, and the ineffable intervention and interpretation. And the use of silence as a therapeutic tool. And then we'll go into different types of silences. So there is a full lecture on my YouTube channel, different types of silences. So the silence is roaring, and the roar is different. There are different colors and flavors of a silence. So that is a dynamic part of what happens. We have done the static part. So next session, we will start with the dynamic part: transference, counter-transference, projective identification, containment, silence, the ineffable O, interpretation, intervention, and use of certain tools to advance analysis or catharsis. Any questions you have? We are nearing time. So what we'll do is next time we will do the dynamic part of therapy. And after that, I think we should take a detour in applying psychoanalysis to arts. Non-clinical application. Yeah.
I did not follow the ineffable oath.
Oh, ineffable O. Bion uses the concept, the ineffable O. He talks about a state in which nothing is happening linguistically, but it's a very strange kind of active containment in which healing happens. And that event of healing he calls the ineffable O. That which cannot be completely defined, but the effects of which can be seen. So in these last years, Bion was fascinated with this idea of the ineffable O. And that is what turned him almost into a kind of mystic. And as usual, the classical community would not like it. They would think of it as diversion from science. So Bion had this very important idea of the ineffable O. So like Lacan, there is an early Bion and a late Bion. And there is an early Freud and a late Freud. And there is an early Heidegger and a late Heidegger. So this is one set of thinkers where the early and the late were radically different.
Ask a blasphemous question.
Yeah,
Please
welcome.
Please forgive me.
Yeah.
Because what I remember from reading the psychoanalysis is once superego gets a little softened after therapy. Does that not happen to our branch itself?
It happens. So
Thank you.
one of my lectures is titled, How Far Can a Word Go?
Thank you.
The title of the lecture is How Far Can a Word Go? Coming to Terms in Psychoanalysis. And this coming to terms has two meanings. One is terms which are used in psychoanalysis, and coming to terms is coming to terms, reconciliation. Now, there, what you have said is what has been the history of psychoanalysis. That we start off with discovery of a concept and we say it's extremely pathological. That is stage one. We see it as pure evil. It has to be overcome, undone, disintegrated, erased. Stage one. Stage two, we say, oh, this is found in normal people also, in everyday events also. So it gets sort of normalized. And stage three, we say there is a healthy form of this also.
Yeah.
So starting with something as extremely pathological, then finding a normal occurrence of it, and then finding a healthy version of it. That has been the history for most concepts in psychoanalysis. And that is where I say, how far can a word go? That the word, which started off as something completely pathological, then means something normal, and now we are looking at a healthy version of it, and still all of that is contained in the same word. We are somehow reluctant to coin new words for them. And therefore, the stretch of the word is so much that it comes to a situation where we say it means everything to everybody and nobody knows what exactly it means. So that is one part of it that's actually true. So what I was suggesting was that after we do the dynamic part of the technique, we can go into the non-clinical application of psychoanalysis, apply it to literature, art, mythology, and so on, and have a couple of sessions there, and then go back to Freud again.
Yes, sir.
Okay. See you then.
Thank you.